through the YouTube channel of the H3Africa. So the presentation would be available and you would receive the link. You'll be able to share also the presentation with other colleagues from your team. We are very excited to have Dr. Bodamir today. A short bio. Dr. Bodamir, I think he is really fitting what H3Africa is. He is an international person. He was trained for his medical studies and his PhD in Germany, and he continued his training in US, where he was at the Baylor, first in London and then in US. And then after his PhD, he also worked in Austria. So he came back to Europe in Austria before going back to the US. And since 2015, he is Associate Chief for Genetics and Genomics and is the Park General Chair in Genetics and Genomics at the Boston Children's Hospital. And his work is focusing on the translation of research laboratory, and his primary focus is therapeutic development for neurodevelopmental disorders. Our speaker is invited today with his all heart that he has, but especially because of his work within the National Organization for Rare Diseases, the NORD, which is chairing, is a member of the board and is also chairing the division at the Boston Children's Hospital. And today is going to share with us his expertise and really the insights behind and around the National Organization for Rare Diseases and how it works at the Baylor Children's Hospital. I personally looking forward to learning a lot from his presentation today. Please note that we are all monitoring the chat. Please don't hesitate to post your questions during the presentation on the chat, but the question will be only answered after the presentation is finished. Please also be aware that if possible, if time allows, you'll be able to take some oral questions, but we will first go through the chat, prioritize the question that has been posted in the chat. So thank you very much, Dr. Bodamir. Without further ado, I'm going to leave the floor to you for your presentation. Thank you.
Thank you, Professor Lumaka, and thank you very much for this kind introduction and invitation to speak today about our experience with the Rare Disease Center. So I divided my presentation today into two parts. The first part focuses more on the NORD, on the vision of the NORD Rare Disease Center network in the United States. And the second part focuses on our own experience at Boston Children's Hospital. And I will give you a few examples on projects that either have already launched or are about to launch as part of the Rare Disease Center initiative. As Professor Lumaka pointed out, NORD stands for the National Organization of Rare Diseases. It's an umbrella organization for patient advocacy. I won't read through all the text, just to highlight a few aspects of NORD. The vision is really such that all individuals with a rare disease should have equitable access not only to a timely diagnosis and quality clinical care, but also have access to clinical trials, research opportunities, and supportive resources. So it's a very holistic vision on rare diseases. No one should be left behind. It's a one-of-a-kind initiative here in the States. And 2 years ago, the idea was born to actually launch a network of rare disease centers that would meet certain quality criteria. And this program was officially launched on November 4th in 2021. And a request for applications was sent out to about, I think, 35 institutions. We all worked on a fairly comprehensive application package. And just to give you some ideas, these applications included questions around staffing, how many geneticists do we have on staff, how many genetic counselors, how many subspecialties do we have access to? And it was also, obviously kind of emphasized that it should be really a holistic care approach, again, in line with the vision of NORD, that the centers would really have to take care from the prenatal setting throughout the pediatric care setting well into adulthood. So it basically focused on the entire cycle of life. There was a second round of applications sent out more recently to another 15 institutions, and I will give you kind of an overview of all the institutions in a moment. So this was extremely well received, and I think it was the first really initiative, at least here on this side of the Atlantic, that focused on the creation of designated rare disease center with a holistic vision. So the first application cycle, as I mentioned, was in last 2 years ago. Second application cycle just opened, and there was a holistic approach, and the centers really had to fulfill all the criteria before a designation was achieved. And of course, then one of the biggest challenge was that some institutions had a sole focus on pediatrics, and they were essentially encouraged to partner with adult care centers. So this gives you an overview of the first set of 31 centers, how they kind of spread across the United States. And you will immediately identify some geographical gaps. So there's a fairly sizable gap in the Northwest, so around Seattle, the big gap there. Then the Midwest has kind of a few gaps. The South west with Arizona and New Mexico, there's a large geographical gap there. But for the most part, the centers follow the urban dense centers of where most of the individuals in the United States would reside. The second round of applications basically is attempting to fill in the geographical gaps that you will appreciate on this map. All centers are committed to rare diseases in general. And following the application process, we also extended the focus onto education. So important aspects of education for primary care referring physicians, primary care physicians is now included in addition to education for individual rare disease patients and, of course, their families. As I mentioned, there is a holistic approach touching on all the specialties. And we also built in a program that allows for a smooth transition of patients as they age from pediatric age, so adolescence, to adulthood, because that typically involves a change in specialty. So that's now also built into the rare disease model. And then, of course, one important aspect, one important advantage of this network is that we are now able to contribute more actively, more proactively to rare disease research, focusing on the development of innovative therapies, and also solidifying care management guidelines to make sure that we always provide best possible care that is as much evidence-based as possible. So the network essentially focuses on this spoke model, where Nord is kind of provides the central platform, and you see the blue dots are the individual centers. And the centers in Nord are linked together by a knowledge sharing platform. We call it intranet. It's essentially a communication platform that allows us to facilitate frequent meetings, frequent discussions. It allows us to share clinical expertise across the network. As I mentioned, shared best practices. It allows also for faster diagnosis, because sometimes, an individual expert from one of the centers may have seen a particular condition before. And when we present a case, I had members of the network in the room who would say, oh, yes, we have seen this before. Could this be X, Y, and Z? So I think it opens up another dimension of diagnostic decision support. We have already started on some collaborative research projects. And of course, the ultimate goal is to improve outcomes for our patients. So one example would be here that's listed, if we have a research project here kind of labeled as A, one of the sites could take the lead on a research project, could initiate a clinical trial, and then this knowledge sharing platform would allow us to pull in other centers who have similar interest or overlapping interest, or actually available patient cohorts that would be amenable for being included into that clinical trial. And then on the other hand, for care management guidelines, there are many centers who have specific expertise on a group of conditions, and they could initiate kind of a best practice project and then facilitate that project again across the intranet, across that platform. The information that is shared across Nord, across this Nord platform, is always vetted. So it's always checked for quality, and we want to make sure that it's as much evidence-based as possible, which is extremely, as you all know, extremely important for clinical management. And this vetted information will then be shared with medical professionals, researchers, and patients, including their families, on the website. And this is essentially shared with the public. So anyone has access to this information. We have identified quite a few unmet needs in the rare disease community. And if I may go through this list here, and we address those unmet needs by establishing so-called working groups. So one important unmet need that I face on a daily basis is really the day-to-day challenge in operating a rare disease center. So many challenges: how do patients communicate with us? How do I communicate with patients and primary care physicians, just as an example? Diagnostic Odyssey is very much at the forefront of our mission. So we established a separate working group for that. There is scattered experience and expertise with rare diseases. So we want to kind of bring that together and also make sure that, on the other hand, we are able to provide care to patients in remote locations. And we have established a telemedicine working group, and telemedicine in the States has really taken off. I would almost say, thanks to the pandemic, that has really changed the landscape of telemedicine. And now telemedicine is well established in most, if not all, clinical centers. We understand that there is an unmet need. On the one end, you have 7,000 or over 7,000 rare diseases, but you only have like 500 or 600 approved therapies. So there is a therapeutic gap that needs to be addressed. The gap is, I think, twofold. First, new therapies need to be developed, and then clinical trials need to be facilitated. And since we are talking about rare diseases, it's not easy, not straightforward for any given center to pull off a large clinical trial due to the paucity of patients at that single center. So multi-center trials are the future. There are gaps in education, so patient family education, primary care education. There are certainly in the States and elsewhere, we are facing limitations when it comes to workforce. We're kind of really struggling in filling our positions in genetics and genomics. So I think that's an important gap that needs to be addressed with how can we, excite the next generation and train the next generation of rare disease specialists. In the States in particular, we have many gaps in insurance coverage. The transition from adolescence to adulthood is particularly challenging. And then we also have, we're facing many inequities when it comes to access to rare disease care, treatments, education, and training. This, I think, is still kind of a big unmet need here in the States and elsewhere, which needs to be urgently addressed. We made sure that we are not kind of single-minded when it comes to what expertise would we like to have included in these working groups. So we really branched out and involved and invited all the other specialties that even remotely touch on rare diseases to be part of those working groups. And I think the working groups that are, I think, the most active working groups are those that have the most diverse faculty included. And when I say diverse, it's not only the specialty, it's also a kind of an equal mix between females and males, and also recognizing diversity from an ethnic standpoint. So I think that's also very much kind of appreciated if we have a good balance there, and just bring in different cultural experiences and expertise. So this was kind of a general overview of NORD and the NORD network, and we have been included in the first round of the applications and achieved designation in 2021. And we already had a fairly well-established rare disease program, and you see the overview here, and we're kind of touching on quite a few different rare disease categories where we have established clinical and therapeutic programs ranging from inborn errors of metabolism to neurodevelopmental disorders to genetic syndromes. So this kind of formed the backbone of the center. And then we partnered with Mass General Hospital and Brigham and Women's Hospital to really complete the cycle of life that's depicted here, with a focus on diagnostics, clinical management, basic and translational research, and the development of innovative therapies. And we did not see the Rare Disease Center in isolation. The Rare Disease Center here at Children's is already embedded into the Undiagnosed Disease Network, into the UDNI, the Undiagnosed Disease Network International. There are NIH Rare Disease Consortia that we are already part of. So we kind of are trying to integrate the NORD Rare Disease Center into the existing collaborations to really accomplish synergies and make best use of the existing resources without reinventing the wheel. So collaboration and networking is essential. It goes without saying, and this is one example. We're kind of participating in two of these rare disease clinical research networks. They are NIH funded. Again, they span across many different rare disease entity, and they typically are multi-center. So they typically span across the United States, with some even extending into foreign countries. So this is extremely well received in already existing as part of a more national network. And then, of course, everybody is aware of the Undiagnosed Disease Network that has been very active in Boston Children's, and Harvard was part of that as well. And this has really accomplished many diagnoses, identified many novel disease genes, and is currently undergoing a transition of sorts. So I think this is a model that was certainly well received and should be incorporated into any rare disease network that is forthcoming. So what is Boston Children's? Maybe just a few slides on to kind of give you a perspective. We are a fairly large institution, tertiary institution, have about 1.2 million clinical visits each year. There are more than 250 specialized clinical programs, and currently we have about 17 to 800 patients enrolled in various clinical trials. We are extremely well funded from an NIH perspective, and health equity, equitable access is part of our mission. So what we really bring together, and it's kind of, again, reflecting, and I apologize for repeating myself, bringing together clinical care, basic and translational research, and of course, the compassion for rare diseases. The Rare Disease Center itself, with the steering committee, so we kind of formed a steering committee that, again, brings in representation of different specialties. One of the most important areas is Diagnostic Odyssey, and addressing the unmet need of delayed diagnoses. We are attempting to standardize clinical care and management. We are also attempting to accelerate therapeutic innovation, but then also accelerating, if there's an existing therapy, improving access, working together with the other centers. And then, of course, most importantly, also reducing health disparities, providing equal access to genetics and genomics care. We are all very familiar with the patient journey through the diagnosis, and I think this figure has been shared many times. I think when I kind of looked at that for the first time, I was struck that where does this journey start? And this journey really starts with the first symptoms and the visit to the primary care physician. So I think there is an opportunity here to really address the Diagnostic Odyssey very early in its course, and maybe with the potential to actually shorten the Diagnostic Odyssey tremendously. This is, of course, on the background that about 50% of orphan diseases or rare diseases affect children. So we kind of see the majority of patients actually present in pediatrics. On average, it takes many years for a diagnosis to be resolved, and sometimes it will not get resolved even after 10 years. As I mentioned earlier, there are only very few therapies available in comparison to the large number of rare diseases that are known. And then typically up to 8 physicians are involved until the diagnosis is finally reached. So let me give you one example out of my own experience. Just briefly present the impact of the early diagnosis. So this was a 6-week-old female who presented acutely with subacute diarrhea, simply was not doing well, some encephalopathy, and pancytopenia. So the admitting hematologist decided to do a bone marrow, which demonstrated megaloblastic erythropoiesis, which really opens an interesting differential diagnosis. And the patient was eventually referred to our center for metabolic workup. And the first thing we thought about was vitamin B12 defects. And this child indeed had elevated methylmalonic acid as a marker of potential vitamin B12 involvement, and was eventually diagnosed with a transporter defect for a protein that is important to transport the vitamin B12 to the cell, called transcobalamin. And treatment was very simple. It was IV injections of hydroxycobalamin initially, and then intramuscular injections of hydroxycobalamin on a chronic weekly basis. And this child now is 14 years old, thriving, normal neurological outcome, and really simple and inexpensive treatment. So it shows you the power of early diagnosis. If this child would have not been diagnosed, I think that the neurological outcome would have been devastating. And this is her at age 4. And like I said, she's now 14 years old. So, the Rare Disease Center really brings the diagnosis and the therapy back to a full cycle. And I think most of you are familiar with this concept where you start out with a clinical phenotype. This clinical phenotype will eventually lead to a diagnosis. And this is, of course, if it's a genetic disorder, we would employ next generation sequencing, so exome or genome, in addition to long read sequencing, in addition to transcriptome. So we can extend this kind of next generation diagnostics to the extent possible that will then identify a variant, and this pathogenic variant or variants in a known disease gene that would already kind of provide you with the diagnosis. Or if it's a novel gene, obviously we would have to opt to do functional studies using different model organisms kind of depicted here. But then I think the next step is crucial. And my vision is that the diagnosis for me is the first step to therapy. Identifying the pathogenic variants and the disease in a disease gene are the first step to therapeutic development. And this therapeutic development could kind of take different forms. It could be a therapy that is based on the individual variant. So I'm thinking about gene editing or antisense oligonucleotide therapy. It could also be that there's a pathway involved that could be manipulated with a certain drug. We're currently working on that for some of the epigenetic disorders. Or it could be a missing enzyme, like in a lysosomal storage disorder, where a company could be enticed to develop a enzyme replacement therapy or a gene therapy if the gene would be amenable to gene therapy. So I think that's the critical step where I think at the moment we're kind of falling short. We're not only falling short on the diagnosis, but I think we're also falling short in translating the diagnostic finding at a more rapid pace to innovative therapies. And then, of course, if you have a therapy, you can go back to some international collaboration. We typically use GeneMatcher and expand your cohort, define the natural history, and then accelerate a clinical trial with ideally good health outcomes. So what we, as kind of part of this discussion, what we decided to do is we decided to really approach the primary care physician who sees the child for the first time when it comes to medical attention. And we want to empower primary care physicians to not to become genomics experts, but to identify patients who are at risk for having an underlying rare disease. And so we're currently developing a checklist, a digital checklist as an app that would take into account physical features from the physical exam, medical and family history, and then provide the primary care physician with some hopefully simple tool to identify those patients at risk. And then we would take those patients that have an intermediate and a high probability score for an underlying genetic condition and invite the family to join a digital platform for self-phenotyping. They can provide additional aspects of the symptoms that brought them to medical attention. But most importantly, we would give them access to virtual genetic counseling consenting that would then facilitate whole genome sequencing. So we're currently launching this project within the next 2 months on initially 100 families to explore what is the yield that we get, what are some of the challenges, can we refine the digital checklist using an AI, artificial intelligence algorithm further, so that we can refine that? And is it then possible to scale that instead of doing it in 2 primary care practices initially, ideally a rural and an urban practice? Can we then rapidly scale this to many other practices? So stay tuned. We hope to have the first results sometime soon. And I'm happy to answer any questions related to that project. And this is kind of really built also on the notion that whole genome sequencing has become very inexpensive. So I think it's not the sequencing that is the challenge. I think it's our ability to phenotype the patient. I think there is still some room for improvement, but most importantly, the interpretation of the findings. One other study that has been done prior to the initiation of the Rare Disease Center was exploring the utility of rapid whole exome sequencing in the NICU. Similar experience on the pediatric intensive care units. And you see that there's a large number of patients that will actually be diagnosed using this approach. The challenge is you have to predefine the phenotype that you will include in such an exercise to provide you with the best possible diagnostic yield. But on the other hand, you don't want to miss any diagnoses. So there are different approaches. Some institutions, they use a more focused approach, and some institutions we sequence everybody who comes to the intensive care unit unless it's for an obvious infection or sepsis. Another project that we are currently working on as part of the Rare Disease Center initiative is to improve clinical care coordination through integrating all the specialties that are involved with rare diseases. So one challenge that families frequently bring up is, our conversations, is that they don't really understand how to coordinate the visits with the different specialties and with their primary care physicians, and they sometimes hear different messages from different physicians. So what we are kind of actively pursuing at the moment is we are developing a specialty clinic resource for families and for the primary care physicians that would allow us to capture all the contact information, the scope of the specialty clinics, and also defining the responsibilities of each key stakeholder. And we call this an action grid. And this is very simple. It's a very simple spreadsheet that I will show you in a moment. And this will actually allow us to capture clinical care coordination and track also health outcomes. And it is as simple as what I'm showing you here. So it contains obviously the identifying information. It contains the specialty program and the provider. And then it basically lists the parent tasks. So you see here in 6 to 12 months, you need to schedule a follow-up appointment with X, Y, and Z, and you include the contact information here. But most importantly, to the right, you also define the goal of that visit. So you can always check off, yeah, we accomplished that goal. And it allows us and the family to track the patient visits and the clinical care that they receive in a multidisciplinary setting. And then I think last but not least, I want to touch briefly on the workforce limitations. At the moment, at the going rate of referrals, we are simply not able to meet demand. There are many aspects to why this is the case. There are certainly geographical reasons and racial disparities. And also, I think a challenge that we face is some of the subspecialties now develop genetics expertise in their clinical domain, which I like very much, but we need to bring them back into the rare disease space and really make sure that we have a comprehensive, cohesive approach. So what we started out is we started developing strategic initiatives with high schools, colleges, and med schools here in Massachusetts, started to partner with professional societies and institutions, and also raised awareness among the key stakeholders with the goal to really bring in talent very early on in that professional development process to get them excited about genetics. We started hosting summer interns that sometimes come from high schools or colleges, and some of them will then say, oh yeah, that's exactly the field I'm looking for, and they will stay on for an undergrad or graduate program. So I think that's key, that we get the communities involved early. I think once the students reach med school, it's almost too late. You get them excited, but then when they are asked to choose a residency, genetics unfortunately doesn't rank very highly on that. So let me summarize here. So with the Nord Center here at Children's, the goal is to address the unmet need of the Diagnostic Odyssey, to improve genomics care through, first of all, really making all the diagnoses that we can using, as I mentioned, the multi-omic strategy, identifying novel biomarkers, and really inform clinical trial readiness. We're actively pursuing to reduce health disparities in adults and, of course, in children, as well as underrepresented minorities with rare diseases. And the ultimate goal is really to enhance long-term health outcomes for everyone. We should not leave the families behind, because there are some aspects, well, the family might not be directly affected with the rare disease, but there are certainly some secondary effects that really need to be addressed, and they should not be forgotten. And last but not least, we should also strive to enhance equitable clinical trial access. And then last but not least, we started together with the Wilhelm Foundation and UD&I a educational program where we would host two talented individuals from developing countries. And I have to say, it's a tremendous pleasure to have Prince Makai and Jerry Mbungo with us. They have so much talent. I think we would hire them on the spot. So I can only say the best. It was a wonderful experience and still is for another week. And we look forward to host additional champions. And, as we refine the program, I think this is a unique opportunity to also spread this program across the Nord network. I think there are other institutions that would be very interested in this, and we can scale this to the extent possible. So this was the most wonderful experience, I have to say, for a long time. So let me come to a close here. Thank you very much for your attention. I wanted to particularly acknowledge the Wilhelm Foundation, Helene and Mick, such wonderful individuals. It's a real delight to work together with you. The Nord staff, I want to just highlight two individuals, Mary Beth, who is the Nord liaison for the Nord network, and Ed Neal, a good friend of mine, who is the scientific and medical director of Nord. UD&I, the working group for developing countries, Domenica, Samuel, and it should read Manuel, not Samuel twice, Manuel Posada and Bill Gall, again, a delight to work with. And then, of course, my own team here at Children's. So thank you very much for your attention, and I'm happy to entertain questions.
Thank you very much, Professor Bodamir. And as I was expecting, your presentation was really instructive. And I not only learned a lot from your presentation, but it also raised questions. I'm looking at the charts. I don't see any question posted yet. I would start with one question of my own. When it comes to the disparity, the way this concept is approached across the earth, if I may say so, is north versus south, and it's east versus west. But we also need to acknowledge internal disparities, like in the same country, in DRC, you would have disparities from one region to another. And I saw on your map that some of the parts were not in the first call. We also have that in African countries, like, for instance, in my country, we have about 110 million inhabitants. We only have a total 2 geneticists and 2 in training. And we don't have the equipment, access to the hospital facilities are limited due to the low income. How do you think that this approach of the node could be implemented or start to be being implemented in countries where you have that such acute limit in resources and human capacities?
Yeah, that's a very good question. I'm not sure that I have a good answer for that. I think, obviously here in the US, we are extremely privileged. We have a kind of a certain level of clinical infrastructure already in place that we can kind of utilize for a node network, for example. In a country like yourself, I think, and that might also be applicable to the US. I think what's really important, you need to identify the individuals who are passionate about this topic of rare diseases. You need to identify the, either kind of 2 levels of individuals, if I may. One are the existing leaders in that field. And then you need to kind of start building from the ground up, kind of a new generation that could then, filter out into other parts of the country. And I think this bottom-up approach is, in my mind, preferred. It takes a long time and it takes a lot of effort to do that, but I think that's what will eventually pay off. I think this top-down approach, I have seen fail quite a few times. It's immensely important to get buy-in, not only at the population level to some extent, but also at the level of your high school students, college students, and really extract the ones that are passionate and that have the talent to educate them to be and train them to be the next generation of, future rare disease leaders. I think, yeah, and honestly, I mean, I'm presenting the ideal scenario here for us. I mean, you saw on the map, there's so many gaps here in the States. I mean, if I think about the rural areas where individual patients have to travel 100 miles, 160 kilometers or so to the next facility that has a geneticist, that's not sustainable for rare diseases either. So we have to come up with a solution for that as well.
Thank you. If I may continue on the bottom-up approach, I see a question on the chat from my colleague from Senegal, Rukaya Ndiaye. She is mentioning that they are having troubles having access to the services that are available through the node. I don't know if you can comment about that or give some suggestions.
So what challenges do you have?
Rukaya, if you may add some comment to your question.
Thank you very much, Emma, and I would like to thank Dr. Bodamer for his wonderful talk. My question is about the collaboration. What kind of collaboration do you expect to have with other countries? For example, as Emma said, in low middle income countries, maybe all the facilities for genetic testing is not available. So do you expect to collaborate in identified cases where we suspect a genetic disease or genetic testing? So this is my question. Thank you very much.
Thank you for this very important question. I think NORD at the moment does not have an official kind of policy to extend the networks and or the collaborations, at least in an official capacity outside the US. But having said that, I can see that individual institutions like ours would be very interested in establishing collaborations between, let's say, a center in your country and us, and we could kind of form these partnerships that would allow us to help individual centers in Africa and elsewhere to face some of the challenges you mentioned. It could be we could certainly partner on the educational side. We can certainly partner on the diagnostic side. We can certainly partner on the research side. I don't see any reason why we could not, but that would not be within the NORD framework. I think that would be based on individual partnerships, but I think networks like NORD might eventually say, we can build this into the network. It's just not in the plan at the moment.
Oh.
But when maybe let me add, if you take all the larger institutions, not only who have genetic representation or genetic and genomics expertise in Europe and in the US and in Canada, I don't see any reason why we couldn't form these partnerships, between institutions in Africa, South America, and us. I think I personally would be very much interested in that.
Thank you very much. We are also very interested. So if you can share maybe your email.
I'll do that right now.
We can be in touch. Thanks.
Okay. Yeah, talking about the collaborations, do you have, based on your experience, the networks and the working groups that you have developed, do you have developed protocols that goes with how to set up a working group and how to determine the terms of reference for a working group document that we might replicate to develop those networks in Africa and ensure that they are based on a successful model?
I think we have those protocols. I would be happy to ask NORD for those to be shared with everyone who is interested.
Thank you. In talking about the transferability, if I may continue on that, there's one about the phenotypes. Do you think that the phenotype that you have collected and the information that you are releasing on the website, they are sufficiently mature in terms of diversity and capturing information from African patients to be transferred on African continent and African patients?
Yeah, I think that's an excellent question. I think the answer is no. I don't think we have enough diversity included that would allow us to really confirm that statement. I think it's very much focused on, even within the states, focused on Caucasian individuals, with some African American individuals and Asian individuals and Hispanic individuals. But I totally agree. It's by no means ready to be used as a reflection of the diverse phenotypes we see across different ethnicities. So that in itself could be actually a wonderful project, to come, from your end to really define the phenotypes in your populations and then share this information, for example, with us to really have a more comprehensive database. I think that would be an amazing opportunity.
Thank you. We are happy to have Professor Sonia from the Institut Pasteur of Tunis. And Sonia, if you may.
Hello, everyone. Thank you so much. Thank you so much, Olaf. Really, it's a great talk. When you talked about workforce limitations, in particular in regard to medical genetics, and so you imagine if it is the case in US, how it is the case here in
Sure.
Africa. And I appreciated very much the fact that you talked about one of the solutions is having people from subspecialties being trained in genetics and genomics. I always say it's easier to train a cardiologist or a neuropediatrician in genetics than to train a geneticist in neurology or in cardiology. So regarding collaborations on education programs or, for improving the genomic literacy of some subspecialties, it's better to have concrete examples that really resonate for the subspecialty, like for example, for instance, for cardiology or again for neurology. So if you talk about specific examples, like also we are seeing now in Tunisia in oncology, it's easier for them to learn and to interact and in particular to collaborate with molecular geneticists and medical geneticists. So how you make it happen? Are there specific programs? So I guess that there are basic things that they could learn about genetics, but learning them with concrete examples in their subspecialties, it will have much more impact and it will really improve even the collaboration and multidisciplinary collaborations. Thank you so much for your feedback.
Sure. I think there are these examples when you kind of look at the subspecialty societies. They, cardiology, as you know, in the States and elsewhere, they have their own professional societies. So those professional societies, at least in the States, have some educational materials on genetics within their subspecialty. We and many other institutions also have that included into the curriculum for the medical genetics training as well as the subspecialty training. So there's material there available. I'll make a note and see how much we can share. I personally don't see any reason why we couldn't share, or at least I could provide you with the information where to find and locate that information.
Thank you.
Thank you so much. May I? Sorry, I have
yes,
question,
Sonia.
if you allow me. Okay. My second question is about the involvement of the families. All the stories that families say about the natural history, it's fantastic sometimes. So how to document that and how to keep it, in particular in a country in which not all the parents are digital natives or they use all the digital tools. So how to collect and structure that type of information? Thanks again.
Yeah, so I can only speak to the experience that we have. And just to give you an example, we came across a kind of rare neurodevelopmental disorder for which there was already a patient advocacy group that collected information on about 100 patients. So what we devised was a survey. It was kind of a mix of open-ended questions and a checklist. And we basically, again, with through electronic means, we send out that survey to the families. And, we were surprised the return rate was close to 100%. So everybody was very excited. And then we let them answer the survey in their own, own language. Most of them were not very familiar with genetics anyhow. They came from different educational backgrounds. So we let them answer the survey with their own in their own words, and then for the ones where we felt that it needed to be clarification, we went back to the families. It's if you have the electronic tools, I think it's obviously easier to email everybody. Otherwise, we would have to kind of do a phone call or meet them in person. But when you do this more at a global scale, it's obviously challenging.
Thank you so much. Merci
My
beaucoup.
pleasure.
Thank you. So we have 3 minutes remaining. Although was not announced, but we have Ellen here from the William Foundation. And Olaf mentioned Jerry and Prince and the Champion Initiative. I think the question from Sonia about the families and advocacy, I think it's one that allows us to ask a comment from Ellen about how the William Foundation is supporting and would be interested in supporting all the rare diseases activities going on in Africa.
Oh, thank you. William Foundation is actually not a, we are not a huge foundation with a huge lot of money, but we are a small foundation and we are working since we are parents by ourselves who lost 3 children with undiagnosed diseases. And now we are trying to do whatever we can to help families. So we are trying, and we don't know yet. We are working on, we have this champion initiative where we are very proud that you, Amy, and Prince and Jerry are working with us and the undiagnosed families. And we are looking at the undiagnosed especially. So we are trying to help undiagnosed patients and all of you who are working with undiagnosed patients. And I reach out to you and ask, we don't know yet how we can help, but we would like to try to help and to set up something. But so please email me, or we are now also having an undiagnosed hackathon in Sweden. And if you're interested to participate there, you're welcome to reach out to us. And I can, if it's okay, I can write
you
my
can put your email, yes.
Thank you.
Okay, thank you very much. Thank you, Ellen. Thank you, Professor Bodamir, for this very interesting discussion and the presentation that preceded. We are looking forward to developing some of the things that you have presented, and for Africa also having this type of network to really advance the agenda of rare diseases, cutting through the diagnostic odyssey, improving the care until the last patient is diagnosed, as you mentioned at the beginning. Thank you very much for all the participants to this webinar. The material will be available through the website of the H3Africa and the YouTube channel of the consortium. And we see each other in 1 month again for our monthly meeting. So until then, take care. Thank you. Bye-bye.
Take care. Bye-bye.
Thank you.
Thank you. Bye.
Bye. Thank you.